So I'm going to talk about basics of catheterization-based hemodynamics. So I'm going to really put it at a very basic level, so not much complications, not much hi-fi things. Keep it very simple. The idea is that the concept that I'm going to teach must be known to everybody. Every DM cardiology resident must be knowing these basic concepts that are there in hemodynamics. So almost all the exams are incomplete without an understanding of the hemodynamic traces as well as the oximetry data that are thrown at you in the Viva. So I always teach my students like how the case presentation, for example, is going to be the same. Like if you do it in MBBS level, MD level, DM level, the case presentation is dyspnea, paroxysmal nocturnal dyspnea is paroxysmal nocturnal dyspnea. How a DM understanding of a case is different from understanding of at the MD level, understanding at the MBBS level is your understanding of hemodynamics and your understanding of the natural history. So that is what differentiate an examination at the level of DM from MBBS and MD level. So you are supposed to have a very good understanding of hemodynamics and very good understanding of the natural history of the disease, whichever clinical discussion that we have. Not only clinical discussion, but everyday, day-to-day case also, you should be having a good hemodynamic understanding. So I'm going to put it at a very basic level. So whenever the word hemodynamic comes, most of the residents feel it's a nightmare. So it's a real nightmare for most of you because you're not exposed, you're not taught in such a way. And it is across India, I've seen, like it's across both DM and DNB exams, more so in DNB, and people at the institute levels are slightly have better exposure to hemodynamics. But rest of the things, especially the people who are interested in coronaries, putting stents, the word hemodynamics brings a nightmare to them. So let us demystify it. So what is the, we'll start, I think I'm not going to make it more interactive. Not going to be in between some didactics lectures and some what I'm going to put in with some of the other things where we will be introducing concepts like. So what is the most, what is the most, what is the most important parameter in this data that is shown? What is the most important data that is shown here? What is the most important observation? It's a 23-year-old VSD PH with severe MR in atrial fibrillation. So, what are the most glaring thing in oxygen saturation that you have? You please, it has to be interactive and we have to put it in the chat box.
All the audience kindly respond in the chat box so that we can have a lively discussion. Yeah, so it says Shreya has said step up in RA.
So, the most important thing that you should note down is very good. The step up is there, but most important thing is the SVC saturation. A
Yeah.
very low SVC saturation in the presence of a normal FA saturation indicates a low cardiac output. So that's like, for example, you will be mostly cardiac catheterization is done by junior people, and you first aspirate a blood from SVC. It looks really, really black. Immediately you call for help. So that patient is pretty sick. You understand that. That is the most important thing that you have to understand. So am I clear? So a low saturation. What is the connection between low saturation and cardiac output? It is about oxygen extraction. Like so, the body is supplying it at 97. If a normal perfusion of a normal patient, you require such an extraction. That means the cardiac output is low. So that patient has very poor reserve, and you have a problem, you have a complication, you will not be able to handle. Like so, if you are doing it alone, immediately call for help. That's the first thing that you have to all know, that a low oxygen saturation indicates a low cardiac output in the presence of a normal FA saturation. But for a patient with tetralogy, for example, you are doing catheterizing a tetralogy, the basic saturation is 80. But if that patient has an SPC of 50, that's okay. Maybe the cardiac output may not be too bad. The extraction is only 30. So you have to understand that. You have to have a basic understanding of that. Then the other question in this is like, how is the step up happening at the RA level with a VSD with PH with severe MR? Why is it step up happening at the RA level? If it is MR, there has to be an ASD, for example. So if it is a large ASD or not, anybody wants to comment? Is there a large ASD here or not?
Yeah, one person has told Garbo.
Okay, it could be gerbold, that's fine. Or there can be TR because the patient has heart failure, the patient has RA pressure of 14, the V wave of 24. So most likely we will be having some patients who should have a TR. So VSD with step up happening here with TR may be having a step up in RA. Can there be a large ASD here? Large ASD is impossible because why large ASD is not possible? Is because RA pressure and pulmonary wedge are very different. If you have a large ASD, the means cannot be so different. Large ASD would equalize the pressures between RA and pulmonary wedge. So the pressures must be same. So these are the kind of things that you have to look into. So that is what is my job now, make it easy and make it all of you understand all these basics that I'm going to teach. So moving further, so these are the basic flow calculation that everybody is should be aware of. So we just take the oxygen calculation and cardiac output. We put the input and the output like wherever is coming and wherever is going. So we calculate it like based on different contents that we calculate. The QS is generally iota minus mixed venous. Like the iota is what is supplying, and then mixed venous is what is coming back from the system. So this is the systemic output. Like so, QP is pulmonary vein minus pulmonary artery. So this is how we calculate various things. One important thing is QEP. Normally, you have Q. Q is always in any physics that Q is always the flow. So QP means is a pulmonary flow, QS means the systemic flow, and QEP means is a conceptual understanding that all of you should have. QEP means is the effective pulmonary blood flow. What do you mean by effective pulmonary blood flow? There can be at times a lot of problems can be there. So there can be right to left shunt, there can be physiological right to left shunt, anatomical right to left shunt, all those things can be there. But what is the effective blood that is going into the lungs to get oxygenation is the what is the QEP, which is pulmonary vein minus mixed venous. Actually, pulmonary vein is what is coming out after oxygenation, and what is coming out in is the mixed venous. So that's how its QEP is calculated. So mixed venous saturation is 3 SVC plus 1 IVC, but many people start ignoring the IVC divided by 4, and many of us routinely don't do this unless there is a reason to do it. So mostly it is the SVC saturation taken as the mixed venous saturation. So what is the typical QPQS in this calculations? Anybody can answer this? What is the QPQS? Even though the flow is also written, but if you are given only saturation, how do you calculate QPQS? Just the saturations are given to you. How do you calculate the QPQS in this equation? So Ananya has written 3:1. So QP by QS. So that means how this is calculated. Anybody explain to everybody? Go back. What is QP?
Can you different sense?
So QP is the things are in the denominator. Pulmonary vein, my pulmonary artery. Whereas QS iota minus mixed venous. So now you put QP by QS, everything is reversed. Am I clear? So now you go back here. So how 3:1 came? So 98 by 68, 30, and 98 by 88, 10, 30 by 10, 3:1. Am I clear? So this is how you calculate QPQS based on the saturation. So that is how you calculate. Everybody has understood this? The importance is everybody should understand. If anybody wants me to repeat again, I will repeat again.
So any
Okay.
doubts, please write in the chat box.
Because these are absolute basics that every DM's resident should be absolutely aware. These are very basic things. While you are calculating also, you should be able to calculate. The advantage of this ratio, QPQS or PVRI by SVRI ratio, is that this takes away all the assumption that we make about oxygen consumption and all those things. That is why this ratio is very important. We'll come back to QEP and QP later. Like we'll come to that. So operability issues. We want to have some teasers. This is the right now the hemodynamic applications are there in mostly operability issues and some traces that are very important. That's where we commonly use it. Like so, 16-year-old VSD with severe pH plus minus operability. So this is the step up, and this is the data that is given to you, and these are the calculations that are made on room air and on oxygen. So previously somebody is asking like, uh, eh, can you measure it by 12 liter by 4 liter? That is 3:1. Normally, it is not given. Even though in this example it is given, but you are expected to calculate it from the saturation that are given. It's not given. It's not given like what that example that I've shown. So you have to estimate it from the saturation that are given. So is it operable or inoperable? More answers, like very few people are actually answering. Everybody should answer. Like you have to commit. Like operable, inoperable. So the PVR is 6.4 on oxygen. Why people who are saying inoperable are thinking like that? PVR SVR ratio 0.22 after oxygen. So when you are thrown a picture like this, what is the most important number in the whole picture? Like the most important number in the whole picture is 16-year-old. That is the most important picture in the whole slide. Understand? The same thing in a 2-year-old, I may have sent the child for an operation, for a surgery. But at 16-year-old, baseline PVRI of 15, you need not do oxygen study at all. That is the important concept that you have to have. So the most important number in the whole picture is that age of the patient. And then FI is 93. And the important thing is QPQS is still 1.5. So what are you going to obviate by doing a VSD closure? Is you are going to eliminate the excess QPQS. That's all you can do. And then remove the systemic PA pressures that otherwise the patient will have. These are the two things that we are going to do in a post-tricuspid shunt. So QPQS is not very high, and the saturation there is starting of FS desaturation. But all of us should have one important concept. So unfortunately, it's a modern era. Everything is, are you pass or fail? Are this patient is operable or inoperable? That is the kind of dichotomy that we want. But unfortunately, nature or life goes on in a continuum. It's a process. So Eisenmenger is not a one day the patient becomes inoperable, or the previous day the patient was operable. It is never going to happen like that. It's going to be a process. As a physician, you are likely to identify where exactly the patient is and what is likely to happen if you close the VSD. So this patient is possibly inoperable. And if you have calculated the PVRI as 15, then you need not have done oxygen study. But one important thing, the caveat that I want to teach here is that commonly we don't get into account the dissolved oxygen content. The moment you calculate the dissolved oxygen content, this is what happens. The oxygen number also, the PVRA becomes 10 Woods units. The moment you put in dissolved oxygen in the same equation by taking into account the PO2, then immediately the PVRA increases to 10 units. So anybody who does oxygen study, you must take into account the dissolved oxygen content. That is the key message from this slide. So you can make somebody operable to inoperable, inoperable to operable by doing these small mistakes. Clear? So
Sir
diagnosis of
told
shunt
two very
lesions.
important things, sir. So can we just
Yeah.
emphasize? I think there were two very important points. So one was the age. If that were always examiner asks about the Paulwood series, that age part. So that is very important. And the method which we use for calculation of these QPQS, that is the, if you read also Grossman, that is the flaw, or we can say that with oxygen saturation, it steps up. The calculation of cardiac output or QPQS, that is a fallacy with this method of fixed calculation of cardiac output. I think very nice case. So yeah.
Thank you. I think this is a very important concept that I'm trying to teach you concepts only here. And then that concept will be very, very helpful in the calculations like. So how do you diagnose shunt lesions? So this is a very important slide that everybody should understand. Everybody should remember this. So whenever there is a question is whether the patient is operable or inoperable, or if you want QPQS assessment as the primary thing, you should take at least two set of samples. The ideal way of sampling will be while going in and while coming out, take sequential sampling. So what I mean by that, you go into SVC, take a sample RA, RV, and PA. And then when coming out, you can take a PA, SVC, and FA sample simultaneously. So that is a very critical thing. The importance is the variations. Like, for example, if you take only one set of sample, the what is the significant step up is atrial level is 11, ventricular level is 10, great vessel level is 5, and any level is 8. That is, if you take only one sample, what is the significant step up? Whereas if you take more than two set of samples, the average of them, then the mean becomes there is a variation that comes to the averages to the mean. Then actually the step up is 7 and 5. So this I think everybody should remember. Like, so what is a step down? A step down is greater than 2% step down with an aortic saturation of 92% is suggestive of a right to left shunt. So what determines, like, for example, oftentimes you are asked, like, is the patient operable, inoperable, all those things, but you have to have an overall conceptual understanding. It is a lot of things come into the picture, like whether it's a pre-tricuspid or post-tricuspid shunt. For example, I told you an example of ASD, VSD, but when it comes to ASD, which is a pre-tricuspid shunt, people can be inoperable at, say, like roughly around 2/3 of the systolic pressures, like, or even half the systolic pressures, people can be in trouble. That's a conceptual understanding that you should have. Yes. Then what are associated lesion, pulmonary venous hypertension, all those things are important. Lung way obstruction, yeah, altitude. You all know that trisomy, other syndromic patients may become Eisenmenger earlier. Then the most important thing is the age, as we have repeatedly emphasized. And there are a lot of unknown influences like genetics we don't understand. So it's a very complicated issue. I think the real tough ones to crack. But for exams, you cannot answer philosophically like this. What are the operability criteria? So for this, you should all remember these slides, even though we cannot use it in individual patients by verbatim what is written here, but that is the best criteria that you can think of. The Woods criteria was 10 units, and that's history. I think Woods series, I don't know why even people are asking, but then if a lot of people are asking, then you have to remember that. So the Lopez O'Leary criteria is the one that commonly is quoted. So 6 is okay with a PVR SVR ratio of 0.3, but a baseline PVR of 6 to 9 and a 0.3 to 0.5 vasoreactivity testing is needed. In terms of vasoreactivity testing, the PVRA should drop by 20. The PVR SVRA ratio should drop by 20 with a final PVRA of less than 6, or the PVRA SVRA ratio of 0.3. That's what you are supposed to look at.
So
So
can you
various
show
vasoreactivity testing has been done.
so sorry
Oxygen,
for
nitric
interrupting.
oxide, combination of both, isoprolol, IV sildenafil, prostaglandins, and all adenosine, all those have been tried. So this is the definitive criteria that is there: 20% decrease in PVRA and PVRA SVRA ratio with the respective final figures of less than 6 units and 0.3 ratio. Other important thing in this thing
Can you
is that
show
about the
step up and step down slide? Students are
I,
asking over there.
I'm happy to share the slides. You can give it to them. Like, I'm teaching slides.
This is
So
recorded.
so
So this
so okay. If you're recorded anyway, I will be emphasizing the important ones again at the end.
Just I wanted to ask you about the vasoreactivity drug nitroglycerin. Is that inhalational nitroglycerin is useful or not?
Nitric oxide, like inhalational nitroglycerin, I'm not sure.
Yeah, actually there was one of the study was done from the Nizams with the nitroglycerin.
The problem with all these studies, ma'am, is that none of them have been shown to have an outcome-based studies. Like, that is the problem with all these studies. You may show reversibility or not, but currently there are two questions that we are asking. One is whether the patient becomes inoperable to operable or borderline inoperability, whether you're able to classify or not. The reaction may happen, but whether the reaction really means operable or not, that I think only one study has looked at it, and that study is using nitrous oxide and oxygen.
That's
So the second question is IPH, whether vasoreactivity is there or not. That is the second question in which vasoreactivity is asked. There, the response to calcium channel blocker on long term is what is the question. And that question has been answered with ipoprostenol, and even adenosine doesn't answer that. Nitric oxide, ipoprostenol, and the treprostinil. These are the three agents that have shown data that if you are showing reactivity with these agents, and there is a long-term response with calcium channel blockers. So you may show reactivity with many agents. People have tried, even IV sildenafil has been tried, and a lot of agents have been tried. We have tried nicorandil also. We have tried, a lot of people have tried different things like. So, but the problem is they all become papers, but unfortunately, there is nothing to suggest that they indicate operability or they indicate response to calcium channel blocker in IPH. So that is primarily the reason why we do vasoreactivity. So the best agents of note is oxygen and nitric oxide. But the problem with nitric oxide that many people whom we think is inoperable will be shown as operable in nitric oxide. So none of them have very good data on the long term when it comes to operability decision. So this is a very important paper that if you want to read about repair and treat strategy, where you treat them with sildenafil, bosentan, and other agents, and then recatheterize them, and then do. But the problem is that these data are very limited, and they are not shown long-term outcome-based data is not there. So that is the problem. If you look at the numbers, they are all very, very small studies compared to what you find in other facets of cardiology. So other important thing that you have to understand is that how many of you think that this patient is operable or inoperable? PVRI of 25.2 with aortic saturation of 81. How many of you think that this patient is operable? So everybody thinks it's inoperable. This patient actually we operated and the patient came out. The important thing is this patient had I did not show you one important thing, that patient had severe mitral stenosis also. So there are some small additional VSDs and the perioperative course was uneventful. And this is the post-cath MVR with VSD closure was done, patch closure of VSD was done. And this is the PA pressures at the end of the after around year of patient like. So the important concept here is this operability, inoperability doesn't work if there is a significant obstructive lesions on the left side. Mainly mitral inflow obstructions like pulmonary vein stenosis, or you have the mitral stenosis severe. If you find severe mitral stenosis, you can just close your eyes and operate. VSD, MS we have operated, a PEDA, MS we have operated. Lot of them, they all become operable. If there is another reason for PVH. So somehow the lungs become protected. Like, so that's another concept all of you should remember. And that works in severe MS, not in mild MS. Clear? Moving further. So we now go to some basic traces like some exotic and some basic. Most of these are given in the exams, shown in the exams for you to identify. So what is this? So many of you would have seen this trace and many of you are writing supravalvular AS. It is right. So remember, like it's always confusing, especially in the exam. You are all tense and you are all cornered by four people, and you are by basically either had a sleepless night before when the next day when you are shown the spotters, or sometimes it happens on the same day after you grueling session. So you are always tense. Keep life simple. So always when you are shown a picture like this, remember that there are three patterns. Like there are three different traces that are there. So you identify 1, 2, and 3. So there are three different types. One is an ventricle type of trace. So you have a tall peak and you have a small ED, a typical ventricular trace. Other one is an aortic trace and the other one is a smaller aortic trace. So the gradient is happening between two aortic forms of traces or great artery type of traces. Then that means it has to be at the supravalvular level in aortic stenosis. Am I clear? So everybody should have this concept like you have to identify the pattern. So mostly these kind of three traces are given. So why the next question comes is why this is not coarctation of iota? Anybody can think on tell me why this is not coarctation of iota? Very good. Ananya says there is no diastolic gradient. So remember, like you are all echo generation. Like whenever you are asked about clinical hemodynamics, clinical findings, or hemodynamics, think of your echo. So in such a tight coact, which is producing a gradient of say more than 120 or so, what do you expect? The diastolic gradient should also be there. There is no diastolic gradient. That is number one. That's the most important difference. And then it's very almost impossible to pull in one go from aortic valve, from LV to aortic valve into coarctation in one go within one beat. That is also not going to happen. That's impractical. Then the other one is the aortic diastolic is also high. So these are the differences why this is not coarctation of aorta. So moving further to make things clearer. So this is so other important thing is when you're talking about HOCM. So is this HOCM? Which one is HOCM? What is the importance? Everybody immediately you are shown. Why the right side one is HOCM and the left side one is not HOCM? Everybody thinks immediately. Everybody thinks anything that is shown with a BPC, broken burrow brown wall phenomenon. Immediately the thing says. Any obstruction, the LV pressure is going to increase. That's for sure. The most important thing is that you look at the pulse pressure. Whether the pulse pressure changes, what is the change in pulse pressure? That is what will tell you whether this is HOCM or is a fixed aortic obstruction. The one on the left is a fixed aortic obstruction. The one on the right is the HOCM. So it's a very important concept at DM level that not every ectopic produced LVOT gradient is broken burrow brown wall phenomenon. Is it clear? So the most important thing is the pulse pressure fall. That is there or not there. So the hemodynamics here, the pulse pressure falls. So now we again come to another trace like this. So where is the gradient here? This is MPA, RV, and RV. So here again, use my same principle. There are three types of things. So then you have an aortic type of trace or great artery type of trace, and there are two RV type of traces. And the gradient is happening between two RV type of traces. So that means this is an infundibular narrowing. This was actually a patient of post pulmonary valve balloon dilatation who had infundibular spasm. So on the other way around, this is actually a, a, a clear-cut gradient that is happening at the MPA and the fullback is happening at the valvular level. So this is how the traces will be different if you have infundibular PS. If you have do a PVBD and there is an infundibular PS, the other important thing is at times you can see a double peak. That also will tell you it is this. So what is this is after a procedure. What is this? You can see wedge pressure and LV tracings are shown. The diastolic components are shown. Especially at a low gradient, low setting is shown. So what do you find like?
That
So
mentioned it's
post
after
BMB, what has
procedure.
happened?
Somebody,
After procedure, what has happened?
what is the wedge tracing showing? Are the waves okay?
So immediately identify the A wave. ECG, all of you can easily identify. So this is the wedge trace. So look at the A wave. The one that is the wave that is following the A wave is A wave. The B wave is the A wave.
What is
The one
more
here is the B
prominent?
wave.
Yeah,
That's a
you
tall
think
B wave.
what
So
is more
post PTMC
prominent?
MR.
Yeah.
So it's very simple. Keep life very simple. Like these are very simple traces. There is
Yeah.
nothing in this. Like, but all of you are when you're shown in the exam, you just falter. So just make it life very simple. So what does this trace show? The mitral area on echo is 0.6 centimeter square. Why there is no gradient between LVED and wedge trace? LV and simultaneous LA tracings have been shown. Any answers? There is significant stenosis, extremely significant stenosis with history of rheumatic fever, 0.6 centimeter square in a 28-year-old. But still the traces are showing at a reasonable heart rate. Very good. Durvesh says it's Lutembacher. Why do you say that, Durvesh? There is massive step up, massive step up happening from 53 to 90, the RA level. Very good. So another important concept that all of you should understand is once there is a ASD, these gradients may disappear in rheumatic mitral stenosis or any mitral stenosis. Then you need not get gradients. Same thing you would have seen echo also. Echo at times it becomes very extremely difficult in adults too. Many people have missed MS in ASD. So you have to be very, very careful because there is no gradient, there is no murmur, everything looks large flowing ASD, but you have to be absolutely certain that you have to look at mitral valve opening. Like fanatically you have to look for it, then you may not miss it. Like that's a very important thing that you have to understand. Even hemodynamically also you may miss it unless you pick it up from extra step up. So this is the other trace. So the trace is shown like the MPA, the LPA, and descending aorta are shown in different colors. Like descending aorta is in red, MPA is shown in pink, and LPA is shown in yellow. So what do you call this phenomenon? What is this known as? Anybody? Sorry. Very good. Ananya says this is ventricularization of PA trace. So what is ventricularization of PA trace? The PA trace, the MPA trace that is in the pink is almost like a RV trace. This happens in peripheral PS and PR. These are the two situations that such a thing happens. The MPA, your catheter is in MPA, but the trace that you are getting is like an RV. This happens in peripheral PS and PR or a combination of both. So there is a significant gradient between MPA and LPA. There is LPA osteal narrowing with PR. It's a post-tetralogy correction who has this trace. It's a very important classical thing that is known as ventricularization of PA trace. So when it comes to cyanotic annular heart disease, so remember that there are three conditions that can produce cyanotic annular heart disease. One is a step down happening. Step down either happening at the ventricular level or aortic level most commonly. That is a step down physiology. That is most likely a PSD PS physiology or VSD PH physiology like Eisenmenger or tetralogy like physiologies. The other important physiology is transposition physiology. That is the oximetry hallmark of a transposition physiology is PA saturation will be more than FA saturation. Or there can be admixture physiology, or there can be rarely combination. In admixture physiology, whichever the chamber in which the admixture is happening between the oxygenated and deoxygenated blood, all the chambers beyond that stream, upstream chambers, all the upstream chambers will show the same saturation. So PA will be equal to FA. So it's a very important conceptual understanding that all of you should have. The moment you see a desaturation or oxygen desaturation, either of the three have to be there. There has to be a step down physiology, either tetralogy or Eisenmenger, or there has to be a transposition physiology, or there has to be an admixture physiology at work. So this is how you should approach any cyanotic condition that is thrown at you. So we'll see with some examples. So not only cyanotic, but everywhere, these are the kind of traces that are shown at you, thrown at you. 18-year-old asymptomatic, acyanotic, S2 widely split, 3 basic ESM at base. Diagnosis, chorioatrial septal defect. So what is it? Anybody thinks it's not ASD?
Previous examples, Church said also some pressure you have to see it should be equal. So mentioned also before that ASD. What was it?
Very good. So Nitesh Rao has picked up. He says it has to be PA-PVC. Why, Nitesh, you are saying that it has to be PA-PVC?
Why not a large
So the
ASD?
moment you have a large VSD which is producing a 13 step up, a step up of 13, it has to be a large ASD. Large ASD cannot have the pressures very different. Like you see the RA pressure and the wedge pressure, they are very different, 5 and 10 mean. You cannot have such a big difference in if there is a large VSD. Very good. So we'll come to some of the approaches, then you will all become very clear how do you look at all these traces that are shown. So you have to carefully look at that. It has to be a partial anomalous pulmonary venous drainage. The 12-year-old actually came as atrial septal defect. So what are the diagnosis?
Get the saturation in all the chambers.
Look at the saturation. Yeah, very good. This is a common thing that everybody generally picks up. So this is TAPVC. But don't jump into TAPVC like that. So immediately you think of what is happening. The moment you see FA saturation is low, immediately look at the PA saturation. FA and PA are same. Then look at what are other chambers which are nearly the same. So from SVC onwards, everything is nearly the same. So this is actually a supracardiac TAPVC. Then not only supracardiac TAPVC, at a 12-year-old, you expect the atrial septal defect to be unrestricted. So look at the pressures, they are also same. The RA and LA pressures are nearly the same. So this is supracardiac TAPVC with unobstructed ASD. The clinical diagnosis is tetralogy of Fallot in a 3-year-old, which is consistent. Like FA is 65, PA they couldn't enter because patient is very cyanotic. So PA they have not entered. Here in the 65, it may not indicate low cardiac output. 47 of SVC may not indicate low cardiac output. That's what I told you earlier. Already FA is 65. There is a clear-cut step down happening from LA to LV to PA. There is a phase, there is a step down. So what is the important thing here? Very good. Ananya says this is Hoffman variant. What is Hoffman variant? So top VSD is always unrestrictive. So that means the RV pressure has to be same like LV pressure. The moment there is a restrictive VSD happens, there is heart failure. What is the evidence for heart failure here? Look at the A wave. A wave of RA of 10. And the RA pressure is 7. And there is a 30 gradient between LV and RV. RV is suprasystemic. The aorta is 90, which is equivalent to LV. Otherwise, tetralogy should have, a classical tetralogy should have same pressures in RV, LV, and aorta. Clear? So this is the important thing that you have to look at. The top with restrictive VSD, otherwise known as Hoffman variant. So what is this? 3-year-old cyanosis since birth. What is the complete diagnosis for this data? Complete diagnosis. Gurinder says DTGA. TGA with intact IVS. Very good. So why do you think this is TGA? First, you start from aorta. Aorta is 70. Then PA is 88. So PA saturation is greater than aorta. This can happen in some transposition like physiology. Immediately you compare the pressures. RV is 95, aorta is 98. So basically there is a mal connection also. PA is 28 and LV is 42. So there is definitely TGA is there, no doubt about it. So LV versus RV is 90 versus 42. 95 versus 42 systolic pressures. So that has to be either a restrictive VSD, small VSD can be there, but otherwise it has to be intact ventricular septum. The other one is mild PS may not be there because the gradient is less than 14. So 14 gradient can be flow related also when you have such a large flow in DTGA. So we will come to what is an exactly significant gradient. So other important thing is look at unrestricted ASD. A 3-year-old is surviving a TGA because the patient should have an unrestricted ASD. Otherwise, the patient may not be alive at this stage. Has to have an unrestricted ASD. So the final diagnosis will be, so look at all these things. Transposition of great artery is not good enough. A good fellow who has been well trained should say transposition of great arteries with intact ventricular septum with an unrestricted ASD. That should be the complete hemodynamic diagnosis of this trace. The moment you reach this level, now you are never confused about whether it is DTG or not. That is the importance of this understanding. The moment you understand everything, you have a systematic approach, you are never going to falter whether DTG or not. You go to the next level in all facets of cardiology, clinical cardiology, echocardiography. You go one step higher, you never falter in the previous step. So that is the importance of these classes. Like, so what are the possibilities here?
Desaturation occurring at which level?
Where is a jump, obvious jump from PA to?
PA pressure is low. So what are the possibilities? Not just one.
Very good. Many of you are thinking it's unroofed coronary sinus. So it's a very typical trace where the pressures are normal. Like look at all the pressures,
Yes.
all the pressures are normal. So there is a step down happening from pulmonary vein into LA. So what are the causes that you have to look at? So there are various causes for such a thing. So you have to look at what is happening to the other areas. Like, so what are the causes? The causes will include, so what is the atrial desaturation? What are the pressures in LA and RA? What are the pulmonary vein saturation? Whether it can be iatrogenic. These are the various things that you have to look at. Can be because of hypoventilation, lung disease, pulmonary fistulas, Epstein anomaly, unroofed coronary sinus, and all those things can be possibility. But look at all these things. Most likely, we are dealing with an unroofed coronary sinus in this condition. So I think we'll have some concretize whatever I've taught you. So you have to have some basic understanding of everything, and you have to have an approach to all these traces thrown at you. That I think will have your life very easy in the exam, because in your exams you have to practice for all these things. Without practice, you cannot uh, fly through an exam. The moment you practice, it becomes very easy. I have seen quite often that a guy who can actually do these cats without any problem. I know that guy. That guy can do almost all the complex congenital heart disease cat he can do. But the moment he is thrown a trace at him, he just falters because your mind is never trying to do work like this way. You're never thrown a trace in your life. But somehow in exams, he always ask like you to whether you understand these concepts or not. So the importance is that somehow you have to practice. How do you make this practice? Some of the tips that I'm going to tell you will be very, very useful for you to practice. Like all of you should be aware of what is the normal saturations and what is the normal pressure in each of the chambers. What is the normal QP, what is the normal QS, and what are the normal numbers? Somebody asked like QP versus QEP. So it's about right to left shunt versus left to right shunt. Normally, you have QP will be equivalent to QEP. QS, QP, cardiac index, everything will be same like QEP. The moment it happens like left to right to left, then when there is a problem happens. So all of you should be able to draw these traces. The moment you are able to draw all the chamber traces, your understanding of hemodynamics becomes very different. So you should always start with an ECG, and from ECG onwards, you should be able to draw an IVC or a JVP trace, which is going to be the RA trace, RV trace, PA trace, and wedge trace. Same way, you should know how to draw LV trace or iota trace. The other important question that is commonly asked is how do you differentiate between an LV and an RV trace? Both of the ventricular traces are slightly different. So the RV trace, the pressure curve is triangular in shape. Upstroke is not that rapid because it has a low dP by dt and it's no sustained peak. And it is very early fall. The pressure falls to zero, which never happens in LV. So these are the various differences between RV and LV trace. So RV pressure is triangular in shape. You can see this, like you remember this diagram, then you will be able to make out. You understand it's made to eject fast. LV is made to eject fast. So it has a sustained peak. LV has a sustained peak. And it doesn't fall very early, LV. And the fall, LV never falls to zero. All these things happen in RV. So either way, you have to remember all this, like. So the important things, you have to have an approach to these pressure data as well as the oxygen data that is thrown at you. So what is the approach? First, you should remember whether they are normal or abnormal. The RA, RV, PA, wedge, LV, and iota, whether they are normal or abnormal, that you have to note down. And then I always teach people to link the pressure next in line. What I mean is, in system, RA mean pressure is linked to RV EDP. Otherwise, system cannot run. Same way, RV pressure, RV systolic pressure is linked to PA systolic pressure. This diastolic pressure is linked to the wedge pressure. This wedge pressure is linked to the LV EDP. And LV pressure systolic is linked to aortic pressure. The moment you link them, all of them, immediately the gradients come up. The gradients will show up on your face. So look at the gradients. And immediately in a congenital heart disease situations, always compare RA versus LA and RV versus LV. So this is the approach that all of you should have when you're looking at a pressure data. Look at whether the pressures are normal or abnormal. Link the pressure next in line. Immediately the gradients will thrown at you and compare RA versus LA and RV versus LV. That's all you have to do in the pressure traces, that pressure numbers that are thrown at you. What are the things that you have to do in the gradients? Like when it comes to gradient, what is the significant gradient? Mitral, any end diastolic gradient is significant, whereas tricuspid greater than 2 is significant. Mean of 5 is significant. Aortic peak is pulmonary is 25, and any vessel it's around 20. That's the standard teaching. Like 2, 25, and 20 is what you have to remember. Mitral, any end diastolic gradient is significant. Mean of 5 is significant across mitral and tricuspid valve. This is hemodynamic significance of gradients. Then pH classification, all of you should know. What is the classification of pH? From mean pressures, how do you classify pH? And how do you classify PVH? Many of you know PVH, but many of you may not know pH. This I think everybody should know. And you may be asked to know about children also. How do you correlate with percentage of systemic? These things I'm not going to teach you in detail, but these are the numbers that all of you should remember. What is mild pH? What is moderate pH? What is severe pH? And all those things. Then again, reiterating, what is the shunt level significance? You have to know if you are taking multiple sets, it's 5 and 7. And if you're taking 11, 10, and 8 is what is the significance. And step down is any step down happening more than 2 with an aortic saturation of 92 is suggestive of a right to left shunt. So it's a combination of both. There has to be a step down of more than 2 with a saturation, the aortic saturation less than 92 is what is this. So the moment you have a step up happening, step up is very simple. So what are the causes of step up at different levels? You have to think like this. So there's always immediately you'll all know, like, okay, the step up at atrial level, immediately you think of ASD. It's very simple to know. PAPVC also comes to your mind. But remember something that there are some things that can go to any chamber. Those are coronary fistulas and RSOB. They can almost go to any chamber. And there always remember one thing comes from above, one thing comes from below. So PAPVC comes from above. VSD with TR or LV to RH and gerbo defect can produce step up at the atrial level. Same way, step up at the ventricular level, apart from VSD, can anybody think of what are the causes? So RSOB to RV, coronary fistula, then what are the other causes likely? Step up at ventricular level, I'm asking. I'm not going to show the slide before you answer that. I told you, no, you have to think like one before, one after. So always think like that. So VSD is very obvious. We are step up at ventricular level. RSOV I told very good. RSOV. Then coronary fistula to RV will be there. What other things will be there? The other things will be, there can be PDA with PR can be there, or AVSD at times, a low ASDR and AV canal actually can show a step up at the ventricular level. This is how you have to remember, like one thing from below, one thing from above. At that level, there will be, that is very simple. Like ventricular septal defect will produce step up at VSD, the ventricular level. That's very easy. RSO will produce everywhere, and then coronary fistula can be from everywhere. So a low level SD. Remember that the mixing chambers, the best mixing happens at the next level of chamber. That's what you have to understand. Same thing at the ventricular, the great artery level, PDA, aortopulmonary window, and outlet VSD, and then coronary origin of pulmonary artery, coronary camel fistula, and RSO, we can rarely open there. Right to left shunt, pulmonary venous desaturation can be because of, we discussed that case, a lot of things can be there. Desaturation at the LA level can be at various causes, severe PS, unroofed coronary sinus, large ASDs, common atrium like. Desaturation at LV or aortic level, Toff Eisenmenger VSD. Desaturation at descending aortic level, PDA Eisenmenger or PDA with coarctation or interruptions. All these are the causes of right to left shunt. So again reiterate the stepwise approach. So in terms of saturation, what you have to do, 4 steps again. Look at whether the patient is cyanotic or acyanotic. Acyanotic means immediately identify the step up happening and immediately find out the cause of step up and look at the gradients and other normal or abnormal. You will be able to identify the diagnosis. If it is cyanotic, you identify the patterns immediately. You identify whether there's admixture physiology or TGA physiology. Just look at FA versus PA. If FA is PA is more than FA, TGA physiology. PA and FA are same, admixture physiology. Then identify where the chamber, which chamber its admixture is happening. Keep life very simple. Or then you look at, if it is not there, then you look at step down, where is it happening? And then look up for step up for in acyanotic congenital heart disease. This is the stepwise approach for saturation. Again, the pressure data, the stepwise approach is normal or abnormal, link the pressures next in line, and immediately the gradients will come up, and then always RV versus LV and RA versus LA, you will be able to identify most of the complicated, complex problems, but please practice this. So don't do this first time in your exams. So that's, I think I'm able to cover the basics, I thought. So thank you for your patient listening.
Dr. Ramakrishna, is really excellent presentation. I had the work at 8 o'clock, but I stayed back just because your flow of the presentation is so good. I can't miss even a single slide. Even though I have seen these presentations previously uploaded in the net, but your explanation is so nice and is really informative. Thank you very much.
Yeah, it was really a great learning that you had given all the students. They are getting confused. They try to look here and there, but the segmental approach and very practical tip you had shared. And I just want to advise them that don't miss the clinical history, which is very important because people try to directly jump the reading. But the clinical history, as your first slide, the 15 years boy. So then you should correlate what you are going to achieve while having the clinical history. And second important thing is the X-ray, the cardiac seal out. And there is a entity called operability in our day-to-day practice. Like if the person is having a 6-minute walk test and it is desaturation, then it is again one of the criteria of operability, whether to cath or not to cath in such patients. Thank you, sir. It was great learning. Yeah. Mhm.
Yeah, thank you, sir. Thanks a lot for such an informative session. I think the questions, queries, and the interest in learning will make us want more sessions. So we have a time limit of 1 hour. I'm sure all the students would want to hear more about this. Maybe in the future we can consider. Thanks a lot for taking time out to teach in this forum. If there are no further questions from the audience, any questions, any queries, anybody wants to ask anything in particular, any clarifications required?
And another important tips, the student should aware about the hardware, like end-hole catheter, side-hole catheter, which are the catheters for the pressures or the wedge pressures, because most of the time they are not aware because the congenital cath, they are not having a exposure. So one should have a systematic what you are going to achieve, what like which pressure, how you are going to take and inject and take the pressure tracings and all. So that is also very important. Yeah.
And one thing I think at the start of every procedure, what we forget is calibration,
Yes,
positioning the
zero. Yeah.
transducer, which can make a significant difference in
Yeah.
pressure readings, especially in the venous system when we are doing. I think that also students should understand before starting of a procedure.
Perfect.
Uh,
Yeah.
yeah, so they have asked whether slides will be available. Yes, this session will be recorded, and we will share the recording of the session with on the Wincars website, maybe in a week or 10 days time. Yeah.
Okay.
Thank you all. Thank you so
So
much.
I'm anyway sharing the slides, so I think they can have it like.
Thank you so much, sir.
Okay,
Yeah.
sir.
Thank
I'm
you,
just
sir.
sharing the slides,
Thank
so I
you,
think
sir.
if they can allow them to download it, I think they will be happy. I think
Yeah,
That's
sure.
very nice of you, sir.
Yeah. Yeah.
Yeah, I think we
just
can upload it on the
mainly my
Wincars.
purpose is to teach only. That's all. Like if people can have the slides. I think I've shared it to
Yeah, you shared on the
the
group,
host
sir.
and panelists. I will again share it to everybody. I think I'll
Great,
just do that.
great.
I've shared it in the group, so but I've shared it to everybody. So I think so that people can just a moment. I will just put it there. It's loading.
That's the quality of a good teacher. Nothing is personal. It's all the students and they can learn from
Oh,
them.
I am able to teach because my teachers taught me. So if I keep it for to myself, it's never going to grow. Like
Yeah, true,
That's
sir.
very
True.
nice of you. That's true, sir. And it was a very enchanting lecture, sir. I just remember going back to my DM days and what we used to, like you said, the coronary people, if you show the hemodynamics, they are get scary about it. But I think that we should be aware with the basics also because we,
you
especially in the
should be knowing
institute when
basics
you're
of
going
everything.
for,
You cannot falter. Like
yes, we cannot falter. And especially in the institute when you have to deal with all the type of patients, not only coronaries, but all the congenital, your structural, BMVs, like the BMV tracing showing MR, you should be aware what you are dealing
Yeah,
with
on
rather than
table only you can make out
table.
what you had done the wrong. Yeah.
Yeah,
Yeah.
I think it's shared. Thank you, sir. Hema, you want to conclude? And it was a very mesmerizing lecture. We didn't
Thank
realize
you,
that you
everyone.
have spoken for 1 hour.
Yeah, actually, this was an amazing. We didn't realize it was 1 hour. By the time you said thank you, then we thought you were exactly at 1 hour and we don't have any more time left. So thank you so much, sir,
Thank you.
Professor Ramakrishnan. I thank you very much, the chairpersons for today's session, Dr. Hetan Shah and Jyotsna ma'am. And I thank Dr. Rupali and Dr. Usha for arranging the session. And thank you all the participants and hope we can do better in future too. Yeah, thank you.
Thank you.
Yeah.
thanks a lot for the opportunity, ma'am.
Yeah.
Thank you.
Yeah.
Thanks a lot, sir.